today is an exception because we have an amazing speaker coming from the US to join us today. And so time zone wise, it made sense to have it a little bit later. So as I was saying, my name is Bianca. I'm a PhD student at the University of Cambridge in computer science. And I have a particular interest in applying computer science to gynecology and in particular to the condition called endometriosis, which affects roughly 190 million women around the world and people with uteri. So big topic that I won't talk about today, but I'm really interested to see how we as a community can work towards improving and advancing our knowledge about women's health using AI. And before we start, I will just very quickly give you a very brief overview of what this community is all about, because this is our first event. And based on that, I will leave the floor to our amazing two speakers, starting with Thomas. So if you have any questions, feel free to ask in the chat. Otherwise, there will be time for questions and an interaction or live interactive Q&A at the end of each talk. So yeah, without further ado, let's start with just very quickly presenting the aim of this AI for Women's Health community. So this is an academic community, and really the idea here is that women's health in general is very broad, and I think I will just very briefly describe what I mean by women's health. I mean by that very broadly every medical and health research question that concerns women or people who are assigned as female as at birth, as well as the transgender community. So in other words, it can be reproductive health, but not only. It can be also breast cancer, but not only. It can also be Alzheimer's disease, which affects women more than men, for example. So it's very broad, and the idea of this community is really to think about the role of AI within that domain. So whether that can be AI for diagnostic tools, whether that can be AI for prognosis, or also the risks of using AI in such a domain. So for example, is AI discriminating against women in clinical trials, for example, or clinical applications? And all these issues that should be explored further. So in other words, and just to summarize what the goals are for this community, which is an interdisciplinary community, including clinicians, but also academics, data scientists, students, designers, healthcare professionals, etc. What we really want to do is build a diverse group of individuals working or at least interested in this field of women's health, with and without AI, and thinking about how can AI help to improve our knowledge of women's health, but also bring visibility to the research that is currently done in the field. And today we have two types of talks. Thomas' talk, which is a project that he completed a couple of years ago, as well as Vijay's talk, which is more like a perspective study or ongoing work in progress project. And also we want to facilitate collaborations between people within this community across fields as well and domains of expertise. So if you have a project that you're interested in and you would like to offer expertise, please feel free to contact others, as well as share resources such as trainings, events, and funding opportunities. That's kind of the point of why we're here. So without further ado, I'll just introduce very briefly Thomas Budenkotter. So Thomas is a scientific researcher at the Department of Nuclear Medicine and Interventional Radiology at the University Hospital of Hamburg-Eppendorf and Jung Diagnostics. I'm not entirely sure how to pronounce that. Thomas completed previously a PhD in applied mathematics, is that correct, at the University of Cambridge? And today is going to tell us about a specific deep learning based model that was used for segmenting multi-site lesions in ovarian cancer. And I'm really excited to hear more about Thomas' work, even though we've already discussed it together. And obviously, if you have questions for Thomas, feel free to ask in the chat. So without further ado, I will stop talking and let Thomas tell us more about his work.
Thanks very much for the kind introduction. I think there's not much more to add. Do you see the right screen? Yes? Good. So thanks for the invitation and letting me present my PhD work here. My full PhD title was Fully Automated Segmentation of High-Grade Serous Ovarian Cancer on CT using Deep Learning. Don't worry if you don't know some of the words. I'm gonna explain everything during this talk. And first of all, this was not my work, but this was really our work. I had the great pleasure to work in a really fantastic team of researchers in Cambridge that came all from a very different background, both from what they've studied and a cultural background. So I really, really enjoyed this work. And I'm also a bit sad that it's already over and that I'm not at Cambridge anymore. Okay, what I'm going to discuss in this talk is first some background, some medical background on high-grade serous ovarian cancer. I'm going to then most of the time I will discuss the automated segmentation algorithm that I implemented. In particular, I'm going to mention some of the details. I'm going to discuss how we clinically validated the algorithm, and then in the end, just one brief slide on how we clinically integrated the algorithm. This is a picture of a fundraiser that we had in Cambridge. So in Cambridge, there is a center that's specialized on ovarian cancer, and these people were from the ovarian cancer team and did a race through the city to raise some money for the research in ovarian cancer. And I like this image because this is quite a nice model of the ovaries. Here, the white thing that you can see is the ovaries. Here you have a fallopian tube, and these little parts here that connect the fallopian tubes are the fimbriae, and they are important for us in ovarian cancer because this is where ovarian cancer actually originates from. These little parts that connect the fallopian tube and the ovaries. And the symptoms that the patients have are typically very subtle, and they match menopausal symptoms. So very often patients who have ovarian cancer in early stage go to their GPs, they describe their symptoms, and then the GP says, oh, you're just menopausal, you can go home and drink tea. But unfortunately, during that time, the cancer is growing and it gets very quickly, it develops metastasis very quickly. These metastases get transported through the whole abdomen by the abdominal fluid and sometimes even beyond. Sometimes patients have already metastasis in the lungs by the time they get their first CT scan. The high-grade subtype of ovarian cancer that I am going to discuss in this talk is the one that accounts for the most deaths. We currently have around 7,400 new cases of high-grade serous ovarian cancer per year in the UK, and because of what I just described, roughly 60% of them are diagnosed at an advanced stage. And then there's two options for treatment. Either the patients get an immediate surgery, or the patients first get a chemotherapy and then a delayed surgery. And the advantage of the chemotherapy is that you can reduce the tumor volume, and there is a higher chance that you can reduce more, or that you can take more of the ovarian cancer out with the following surgery. Typically, if the patient is diagnosed at an early stage, the treatment can be curative for the patients. But as I said on the previous slide, 60% are diagnosed at a late stage. And these patients typically face many recurrent episodes of disease. The disease-free intervals get shorter. The tumor cells start to develop chemotherapy resistance, and ultimately the most common cause of death is a bowel obstruction. And especially this chemotherapy resistant makes ovarian cancer really tricky to treat because, as I just explained, the ovarian cancer is typically spread throughout the whole abdomen, and if even just some of the cells are resistant against chemotherapy, they will survive the chemo, they will spread more, and then the whole cancer is resistant against chemotherapy. This makes the treatment really difficult. And one of the reasons why we decided to study ovarian cancer is because there was really limited progress on ovarian cancer. Some people go even as far as saying that the survival rate of 5 years hasn't changed since the 1980s. And this is really unique for a cancer. Typically, the survival rates of cancers improved over the last decade. For ovarian cancer, this was not the case. So here are some images and some examples of how ovarian cancer looks like. This is the primary tumor in the pelvis and ovaries. And in case you didn't know what a segmentation was, this is basically what we're looking for when we're trying to do segmentation. So when radiologists think of segmentation, they mean this blue contour here. They want to discern where the tumor starts and ends. When I, as a mathematician or as a computer scientist, think of a segmentation, we think of classifying each pixel in the image. So these pixels here are classified as non-tumor. These pixels here are classified as tumor. And this segmentation of really saying which part of the body is tumor and which is not tumor, this is really what we're looking for in segmentation. This is the second disease site, the second most common disease site. So basically, you can already imagine this as a metastasis. The omental disease typically spreads through the whole abdomen, often in the belly fat. And as you can see, the structures are very complicated, and you can imagine that it was very, very difficult in this case, for example, to resect every single piece and bit when you're trying to do a surgery. This is why in Edinburgh's we often try to do chemotherapy. And the question is now for us, if we can get such a segmentation, how can we improve the treatment of the patients? And one thing that we found out, or one vision that we have, is that we want to create predictive models for treatment response. So we want to create a model that looks at a patient and then predicts how the patient will respond to the chemotherapy. Because if we have this, then we can personalize the chemotherapy. Maybe we'd switch to a different chemotherapy that we would have not chosen in the first place, or maybe we can see that the patient is resistant to chemotherapy at all and that we should start straight away with the surgery. So this is really one vision that we have. And to build these predictive models, there is a lot of different information on the patient and the disease necessary. So some semantic information from the radiological reports, like the ascites or pleural effusion, clinical information, age, stage, treatment regime. But one component that we found to be very important are these radiomics. So they basically take the CT scan, they look at these segmentations, and they compute different statistics like the shape and the volume of the tumor, mean or median gray values, texture, and these features all together boiled in one pot can give you a predictive model. And we already did this in a paper and found this to be a very promising start for this project. A second application that we have in mind that is important to support clinicians with is that we want to replace the current measures that are used to assess treatment response. So typically what's been done in clinical practice at the moment is called RECIST 1.1. The radiologist would just scroll to the CT slice where the tumor is the largest and then just measure this diameter, which is basically the longest line that you can put inside the tumor. On the left, you see the pre-treatment scan. On the right, you can see the scan after the neoadjuvant chemotherapy. And if you would look at the two numbers, you would see, 35 millimeters versus 51 millimeters, that's bad. The patient didn't respond to the chemotherapy. You should switch chemotherapy. But if you actually change the contrast in the image a bit and look a bit closer, then you can see that this tumor here is solid, while this tumor here is filled with fluid mostly. The fluid is not dangerous, just the solid part is the dangerous one. And the volume of this solid part is actually reduced. So the patient did respond very nicely to chemotherapy. These RECIST measurements, they don't cover this up. They would just naively look at the whole volume. So in order to get a better idea of how well the patient responded to the treatment, we want to compute volumes of the tumor and in best case even compute sub-segmentations and look how large is the volume of fluid, how large is the volume of solid components of the tumor. So these are basically the two most important applications of segmentation. As I mentioned earlier, it's important to actually capture all disease sites. We have many disease sites in ovarian cancer. And this makes it really tricky because the two disease sites that I showed you at the ovaries and pelvis and in the omentum, they are very common. They account for a lot of the tumor burden, but there are a lot of other disease sites that are less common, and especially finding the very small tumors in the very rare locations is extremely difficult, both for humans and for radiologists. So to summarize that quickly, how can we use AI-based segmentation to support ovarian cancer treatment? The first one is that we can use this to create response prediction models and then use that for personalized treatment. And the second one is to enable volumetric assessment instead of using the rhesus diameters. So we went ahead and said, let's create a segmentation algorithm. Some of you already might be familiar with this U structure here, this unit, and we use deep learning-based algorithms because at the moment they're state-of-the-art and there's nothing that can compete really with deep learning-based algorithms for such complicated 3D segmentation problems. And the building of such algorithm is actually very technical and I think also a bit boring. So I will not go into too much detail, but basically how it's done, you take a baseline model where you know that it works very well on generous segmentation problems. You would train it on your data set. You would identify some potential changes that you can do to the model. It's really engineering. It's really like a big machine with a lot of screws, and you think, oh, maybe I screw this one left, I screw this one right, and then you check if it's getting better or not. It's really a lot of trial and error, and you repeat this and get incremental improvements until there is no improvements anymore. Then basically you got everything out of the data that you could, and you have the best model that you can. This is basically what we did, and that's what I did in my research in my PhD. And we got a model that was significantly better than the baseline. We were very proud of this because this baseline that we chose was already very strong. We were happy that we could improve this. And one of the most important results that we found is that with my tuning, my model got as good as a trainee radiologist with 3 years of experience, at least for the primary disease site in the pelvis ovaries. For more difficult metastatic disease sites like the omentum, we could see that there was still quite a large gap between the trainee radiologist and my model, but at least we already could make a large step into the right direction compared to the baseline. Now, going back to the applications, we wanted to measure volume of the tumors. So we compared the ground truth volume with the predicted volume, and we were quite happy to see that it's matching quite nicely. Of course, there are some outliers, and there should be a lot of critical testing being done where you check how bad these outliers were. But in general, we see that at least roughly you can measure the tumor volume with our model, even though it's not perfect. That was valid for both disease sites, and it was also valid when we looked at the tumor shrinkage instead of the volume. So we looked at the difference in tumor volume before and after treatment. Also, that could be predicted with our model. And this is why we think that this model might already be useful in clinical practice. But this is not enough. We need some more clinical validation to really know what the capabilities of the algorithm are, to really find out what the shortcomings are and where the mistakes are. So this was the second part of the work that I did. I did it closely together with Cahal, who's writing his PhD thesis on the same problem, but from a radiological point of view. And the reason why we did this is because in deep learning-based research for segmentation, there is a lot of work that actually shows that if you only compute some simple metrics like die score or volume, these are not enough to really get the full picture of how good the segmentation is in practice. So we thought of different ways to validate the algorithm in practice. The first one that we applied was the visual Turing test, named, of course, after the famous Alan Turing. And the idea here is that there is a player or interrogator C that gets to ask questions and receives answers from A and B, and the player C looks at the questions and has to decide whether A or B was the machine. And if C is completely unable to find out if A or B is the machine, then you can consider the A to be as good as B. We applied this to ovarian cancer and to imaging by showing the interrogator a scan, showing them a segmentation, and the interrogator then had to choose whether they thought it was a manual or an automated segmentation. And we were comparing how often the interrogators were correct in their assessment. The results of this was that the interrogators actually could distinguish the human and the AI segmentations. So you can say that there is a difference in performance. It's not large. They had a chance of roughly 60% of guessing correctly if it was AI or manual, which is not much. But the very interesting result that we obtained here is that highly experienced experts of ovarian cancer were as good as medical students. And this is really interesting. And it tells us that the AI makes some images, makes some mistakes that are so obvious that even medical students can detect them. But the AI also produces some segmentations that are so good that even highly experienced experts can distinguish them from real segmentations. The second clinical study that we applied to check how well the segmentations were is that we try to assess the quality of them in a different way. The workflow that we have in mind when applying AI is that first CT scan is acquired, then the AI segmentation is applied to the image, and then in the last step, a human reads the image plus the AI segmentation, corrects the segmentation, and uses this instead of just creating the segmentation from scratch. The first thing that we assessed was whether this speeds up the segmentation. And yes, the interrogators, the radiologists actually got faster by 30%, which is quite nice. So again, there is clinical utility to this algorithm, even though it's not perfect yet. And the second result that I found very nice and that we were all very happy about is that we checked the quality. For each scan, we had one segmentation only done by a human, one segmentation done by the human, the AI, and one by the AI, and we let an experienced radiologist rate which one of them is second, best, and third in quality. And the human plus AI segmentations actually were best in 70% of the cases, which I think is very promising. So this means that even though my AI doesn't reach perfect quality and doesn't reach the quality of a trainee radiologist for the metastatic diseases, we can already see that it saves time in segmentation, and we can see that it improves quality of a trainee radiologist. So then we were very happy about it, and we said, okay, let's integrate this into the clinical and research routine so that the radiologist can still easily use it when I'm gone. And this is work that I did together with Lorena Escudero. So basically, this interface, what you're seeing here, is what the radiologist now can use. They are looking at a CT scan from our database. They're loading it into this view that you can see here. They can access it simply via a browser. And with a few clicks, they can select this NVIDIA AI assisted annotations, which we installed in the browser. They can select the segmentation tool, the ovarian cancer segmentation model. They click run, and then the CT scan gets sent to a GPU cloud. The results are being computed in 1 to 2 minutes, and the results are being copied back. The results are being visualized here, and now the radiologist can start annotating and start changing the segmentation such that they agree with it. And we were actually quite surprised how simple that was. It cost us, I think, maybe a few weeks of pain. Of course, if you do such software engineering, it's always a bit of pain. But in the end, we were quite happy with how stable that was. And I'm also quite happy that people in Cambridge are actually still using this and still use my algorithm. So to conclude, the deep learning-based segmentation of ovarian cancer is feasible, and we can achieve performance of a trainee radiologist already for the primary disease site. We saw that the deep learning model makes mistakes, and it makes some mistakes that even med students can detect, but the model also produces segmentations are so good that experts can discern from manual ones. We saw that deep learning models and radiologists are great collaborators. They work really nicely together. It really looks like AIs and radiologists make different mistakes, and these different mistakes, basically add up to a better segmentation quality. And we saw that the clinical integration using a pipeline like NVIDIA Clara is feasible when you have such database, when you have such viewer, then it's possible to actually integrate these models using NVIDIA Clara. I would like to spend my last slides on challenges and what we need now to really go on. So the performance is already quite good and quite promising, but I think we need even better models. It's one of the main things that we should develop in, and for this we need more data and we need better algorithms. So basically more compute time to push the tuning even further to limit, to create better models, and yeah, ultimately also more data, more annotated data always helps to create even better models so that we can raise the quality of the automated segmentations even further. Even though we already did some experiments, we need to further understand the clinical utility. So I talked about the volumetric assessment. I talked about this RECIST measurements of the diameter, but we need to do more research to really understand if this volumetric assessment is ready to replace this RECIST. And ultimately, I think clinicians are only going to use this algorithm if this correction of the segmentation is not much slower than the RECIST. If it takes 10 times more time than the RECIST, I think it might be difficult to convince them to use the segmentation instead. The next challenge we are facing is to create the prediction models for the personalized treatment. We need to make the models accessible so that many radiologists can use them and not just the researchers in the Cambridge facilities. And in the end, another difficult point of what we need to do now is we need to convince radiologists and oncologists to use it, because these people typically have their established workflows. And every time you change the workflow, first things go a bit bad, and then only then it improves. So I also think this last point of really convincing people to use this and to use AI in clinical practice is not too easy. Okay, and that was it. Thanks for the attention.
Thank you very much, Thomas, for this very comprehensive talk. And we have a lot of questions for you already in the chat. So I will sadly refrain from asking you my question. And how about we just read them in order, starting with, I think the first question we had was from Gemma. And one was about the CT images collected and whether they were collected with contrast, and what was the size of the training data set.
Yeah, that's typically contrast enhanced CT images. Typically a late phase acquired at a late stage. We acquired the training images in Addenbrooke's hospital. It was around 270. And we got some images for testing, I think around 100 from the Barts Hospital in London, and then 50 from the US, 70 from the US. And at the moment, the people in Cambridge acquire more data and annotate this to get an even larger training set for the new improved version of model.
Great. And actually, that's kind of similar to the, well, not similar, but like following up on that, Anna Maria had a question about how you go about closing the gap further between the model and the trainee and improving the accuracy, I suppose. So would you focus on the data set or the model first?
Both. I would basically, we're trying to annotate more data in the background. And then I would use, if I would start over again with this algorithm, I would basically take all the data that I have at the moment, optimize the model further and further and further. And only once there is a substantial amount of new data, I would integrate it into the training data set. Because if you train a model and you keep changing the training data set, it's very difficult to see if the improvements that you made came from the new training data or from the changes in the algorithm. So I would basically take the new data set that we have now in Cambridge. We also have a lot of unannotated scans, which makes it more challenging to train, and then wait until there's more annotated data and update basically almost in a cycle.
That makes sense. Thanks. And next question from our other speaker, Vijaytha. Did you find that there was a difference in the level of clinical complexity in the cases spotted by medical students as erroneous and those predicted correctly?
I think we did not look at the clinical complexity in this detail. Kahal, who was the radiology PhD student that I talked about, he was looking at all the scans again, and we were also collecting more qualitative feedback and also free text feedback. But I think that we did not see any correlation between complexity of the scans and the likelihood that the interrogator correctly identifies the segmentation as an AI-based segmentation. But basically, often it was just wrong contours, or there was something that the AI recognized as tumor that was obviously not tumor.
Right. Sorry, I'm just firing questions at you, but
No, it's fine.
loads,
Keep
so
going.
that's good. That means that people are engaging. So the next question is from Dilara, and she was asking about the NONU unit, because she said that it came out in 2018. So
Mhm.
it's still considered novel, state of the art in terms of architecture and pipeline, and as a baseline model. And also, are you aware of any common alterations to the pipeline, like replacing the encoder with a more novel one?
Yes, I agree. Even though a unit came out in 2018, I would still consider it state of the art, at least when it comes to untuned models. So the state of the art models at the moment, they just take an unit and then they change some things, but what you change some things and then they are happy that they got an improvement. And there's a lot of changes that you can do, for example, changing the encoder of the model. But I think this should be done for each problem individually. And if there was something like this 2 parameters that you should change to get a better performance, I mean, maybe there are, but then you need to do a quite large scale study where over 10 problems you show that the learning rate is always good to tune. So yeah, it would be nice if someone would do this research, but it costs a lot of time and a lot of compute. Basically, what I always do as the first steps to improve upon NNUNet is that I check the resolution after the pre-processing, because NNUNet uses a very fine resolution. Typically, you can go on a more large-scale resolution without sacrificing performance. Then checking the patch size of the input for the NNUNet is useful. Changing learning rate and batch size is good. And also NNUNet always tends to be either too sensitive or too precise. And you can try to modify, for example, the sampling or the loss function, that sensitivity and precision are more balanced, because then typically the die score is the highest. And that's how I first go ahead, and then looking at errors, see what you can do. And it's really a lot of trial and error.
That makes sense. And then I think we have another 2 questions, but we'll have to move on to our second talk afterwards. So there was one question from Ola about what women is the base model trained on in terms of ethnicity and age and etc. Like,
So I cannot say anything about ethnicity because I got the data set blinded. So it was anonymized when I got it. So ethnicity, at least, was not available to me as a factor, so I can't say anything about this. And regarding age, it was the typical age distribution that we see in ovarian cancer. I mean, we know from literature which cases occur and how the age distribution is in ovarian cancer, and we checked and it roughly matched. So Addenbrooke's is a specialized center for ovarian cancer, and the patients that we got there got typically stemmed from other hospitals to Addenbrooke's, because they know Addenbrooke's was specialized in ovarian cancer. So it's, I would say, quite a good, it matches quite good the distribution of ovarian cancer patients in the UK.
great. And then final question, unless anyone else has a question, but perhaps we can keep that for further discussions with you, Thomas. So Gemma was asking about how did you engage with the radiologists to collaborate with you on this project?
Actually, I didn't engage with them. So my 2 supervisors wrote a joint project together, and I asked my just told my supervisor I want to do something applied, and she said, "Oh, there's a great project with radiologists. Do you want to do it?" And then I said yes, and yeah, we met very frequently. Especially when the pandemic started, we started to meet even regularly, and we had a lot of exchange. Especially that was extremely helpful to me to understand the problem, and also for them to understand the AI-based segmentation. So yeah, I hope that answers the question.
Yeah, basically it was a team project, as you mentioned earlier. You were not the only one.
Exactly.
As you would expect from such an ambitious project, so that makes sense. Right, well, thank you so much, Thomas. I
It
think
was a
that was
pleasure.
very, very interesting, a lot of information to unpack here. And I think your colleague, who was cited in the paper, is here with us. And thank you also for taking part in this amazing project, Cathal. I don't know how we pronounce your name, but hopefully that's correct. And yeah, without further ado, let's move on to our second speaker. So Vijaytha Murali, who is a UK-trained physician, and postdoctoral fellow at Stanford University. And today, Vijaytha is going to talk to us, about defining standards for ethical reporting in health AI for pregnant populations. So without further ado, I will, oh, perfect, you already have your slides. Wonderful. I'll let you move on.
Hi, everyone. Thank you for having me today, and also thank you for accommodating my time zone. I'm Vijaytha. Thank you also for the kind introduction. I'm a UK-trained doctor. I trained in Edinburgh and then Birmingham, and now I'm pursuing dermatology and AI, actually, so pretty different from the last talk in Stanford. So it's the second of my 2-year fellowship, and a large focus of my work is on equity and standardizing ethical reporting. So I wanted to talk to you today about some of the work that I'm leading here in Stanford for developing ethical reporting tools for special populations. I know that term is not used everywhere in the world, and certainly by special populations as defined by NIH standards. In the US, we talk about pediatric patients, we talk about maternal health, and then we also talk about other vulnerable populations such as elderly care patients as well. So it's a little bit about me, and this is some of my team who couldn't be here for this talk here today as well. So some of them you may know and have been involved in some of the broader consensus guidelines, such as Consort and Spirit AI, that have been developed in the UK. So yeah, so the real impetus behind this work was the development of AI guidelines. And so in contrast to Thomas's talk, I'm coming at it from the other side of kind of clinical measures and ensuring consistency, standardizations in data sets, but also in training and testing of algorithms. So this was a paper that was published in Nature Medicine in 2022, which said that ethics methods are required as part of the reporting guidelines for AI in healthcare. And this is some of the work that has followed on from that. And similarly, as you may know, there are now guidelines for clinical trial design and reporting, even though they aren't tailored specifically to any particular specialty or vulnerable population. So one thing that we realized after looking through the guidelines that were published was that there are very few stipulations and guidances for populations that have different ethical needs, be it children, be it maternal health patients. And currently there are really no guidelines or frameworks that really deal with the intricacies and the nuances of these special populations. And so our first piece was actually focusing on pediatric patients. There are many FDA regulated devices that have already been released in AI and ML for pediatric patients, but there is little to no data on who they've been tested on, who they've been trained on. There are many cases and instances of mixed data that we are finding in public data sets, certainly in the dermatology field, where, for example, pediatric data is being labeled as adult data and vice versa. So we really felt a need to kind of start the work as to standardizing some of these. So just to give you some context, our first piece is called Accept AI, and that will soon drop in Nature Digital Medicine, I think 2 to 3 weeks time. We're just doing the formatting, where we're looking at pediatric data and looking specifically at age, consent, communication, equity, protection of data, and technological specific considerations in data set diversity. So that will drop very soon. And this isn't, I just want to preface that this isn't designed as of yet to be a formalized guideline, but really it's a tool to check equity and biases within data sets, stemming on from some of your earlier questions in the last talk. We really wanted to kind of just give you a snippet of our pediatric data set, so then we can talk about this in the maternal health context. So for example, in age, one of the stipulations and recommendations of our framework is to ensure the patient's chronological age at the time of study. ensure that in kids that the developmental age is included, relevant milestones, which is also very relevant in maternal health studies, which I'll come on to, and also specifying very clearly the intended age of algorithms users. So for example, is an algorithm designed only for kids? Is it for adults and kids, or is it for only adults? And that's really important to avoid mixing of data and potentially drawing erroneous conclusions when we're really taking these algorithms to the implementing and testing phase. And similarly, I won't labor on this too much, but for children specifically, communication was a huge part of it as well. We also go into data compliance, and some of this is covered in the broader guidelines, but again, we tailor this specifically to issues around children. And really what I want to talk about today is the work that we're doing to extend this to other special and protected populations. So we're currently working on the geriatric tool. So that's going to be revolving around 5 AMs, which is one of the key frameworks that geriatricians use to assess their patients holistically, from mentition to medication. So that's a really important one. We're also tailoring this framework to small disease groups, so rare diseases that again have a very different set of ethical considerations. And the third group that we're really passionate about extending this to is maternal health. And again, I want to preface to say that I'm not a trained maternal health specialist, but I do recognize that we really need consensus here for several different reasons. The first being that maternal health populations do have their own ethical concerns. Second being that there are many papers out about how underrepresented maternal health populations are in research broadly, and certainly with the advent of AI technology, we don't want to worsen that gap. And I think there are some very pressing issues in digital literacy, equity, ensuring that maternal health populations from different communities are involved in AI health methods are just really, really important. So that's one of our next goals. And so like Bianca said earlier, this is a preliminary talk to gauge interest, to gauge thoughts about where we might be able to focus this, but also potentially to seek collaborators for this effort. Again, I just want to give you a quick snippet of the geriatric piece as well, so that you can kind of visualize in your mind what it might look like when we tailor this to maternal health. And similarly with rare disease. So some of the work that we have started is really by looking at classifying usage of AI in maternal health so far, and really looking at the literature has helped give us some sort of guide as to how we might want to structure a framework here for the development of basic standards that technologists, clinicians, evaluators, and policymakers probably need to look at when we're evaluating and implementing these algorithms. So one way that I really like looking at it is looking at it right from kind of preconception to postpartum care, and really seeing and trying to elucidate what the key ethical and practical barriers to research in these communities might be before we lead to developing kind of a consensus and a framework. So these are some key studies that I really liked. So there are studies looking at predicting pregnancy through IVF. There are triage studies looking at the use of algorithms in ultrasound diagnosis, in obstetrics. Lots of papers on fetal heart monitoring and pregnancy surveillance. Some very interesting papers about warning systems for maternal and fetal mortality, so risk prediction, kind of similar to what Thomas was talking about in the context of ovarian cancer. Screening, prediction of perinatal outcomes, which could be very important in lower and middle income countries as well. And also looking at postpartum care. So this was one way that I thought of, really kind of breaking down our initial analyses and trying to really elucidate, what are the practical issues that we see in collecting data from patients in these different categories? What are the different ethical needs? Are there any specific considerations that we should be giving to kind of consent and equity? Are there specific stages in the AI life cycle for each of these different classifications that we really want to look at whether we are encompassing diverse data from as many patients as we can. And this is, of course, a really big problem in international research, where we have very many different guidelines, laws, and stipulations about gathering data from different different populations. So this was kind of one way that I thought of looking at that. And really, we are open at the moment, and we still are very much brainstorming about whether we should be using a similar framework to the pediatric piece, where we look at those 6 components of potential data sets, looking at age, consent, communication, equity, protection of data, and then algorithms specifically, or if there is another way of looking at that. So, some of the key considerations that I've already discussed here are really looking at the pregnant population, maternal health population as a different. We really have to try and elucidate what the key ethical issues are first. And I don't think there has been much research done in this field at all. There have been some review papers that have come up, but I think that particularly given the different stages and different maternal and fetal concerns that might be at each stage, I think that it's really worth digging more deeply into this. Looking specifically at underrepresented pregnant populations as well within obstetric research, and seeing, are there language barriers that we could surmount to involve more pregnant women, for example, into more corroborative AI research. Really trying to think about costs and implementation, and also really thinking about where we might be able to involve end users, for example, in co-design, which I don't think till date has been done in maternal health either, which is really important. And it's something that we're talking about a lot in the context of pediatric algorithms, and also algorithms that are looking at rare disease where there's a lot of genomic data as well. So really, it's a very preliminary talk. We are very much at brainstorming phase. We have quite honestly struggled to find a really engaged community that are very passionate specifically about maternal health, and that would be interested in trying to eke out these themes and really trying to work out where this might fit. And most importantly, we don't want to be generating frameworks just for the sake of generating frameworks, but really thinking about why guidance is specific to maternal health and might be useful, and where they might be useful. So I just wanted to, I didn't want to talk for too long, but I really also appreciate the opportunity to be able to air some of these thoughts. And I'd be really interested to hear your feedback, your thoughts, and any interest or synergies as well. So thank you.
Thank you very much, Vijaytha, for this really interesting talk. And I appreciate this is like a new project, so it's not easy to present something that is work in progress, but really, really interesting. I would like to second Ole's comment saying that this is a timely and important subject. So thank you for presenting that today. I think there's one question from Maria Beatriz. When talking about pregnant women in clinical research, are you considering the ethical implications for both mother and fetus?
Absolutely. Yes. I should have been a little bit more clear about that. Yes, I think absolutely. I think we need to do that. And that was one of the key kind of impetuses behind breaking it down into those specific timelines and timescales, so that we could look at it from both angles. Yeah.
And that's my question this time. Would you be able to give an example of the ethical considerations that could be highly critical in that context? Because you mentioned there were different according to the populations, like, for example, rare disease, but it's not very clear to me. I've never worked in maternal health. So would you be able to give an example?
I think a key example as a medic that really is pressing on my mind a lot before I designed this reporting aspect was kind of the obstetric diagnoses of trisomy 21 and kind of chromosomal disorders, because I think that there is a lot of in kind of prenatal and antenatal care, a lot of potential considerations for both for maternal health specifically, but also fetal health. If an AI algorithm does, for example, detect a chromosomal abnormality, whose responsibility is that to, where does the accountability lie? Whose responsibility is that to pick it up within a specific time? Who's going to communicate both the finding, but also the fact that it was detected by a technological mechanism, which is potentially, as Tom was saying in his talk, which is not necessarily 100% accurate. Will that have implications in generating further tests? that need to be done. You know, these are all the questions that run in my mind as a key example of looking at both maternal and fetal health. And so I think that AI specifically in that field is going to have a lot of different implications on how we communicate, how we disseminate information, and most importantly, given the sensitivity of it, how we deploy AI within that space, I think is going to be, you know, really interesting, but will elucidate a lot of, I think, ethical tensions around consent, capacity, communication, and also what we do with the findings.
Yeah, and following up, you mentioned the ethical tensions. I also cannot stop but think about the legal implications as well. Is that something that you also consider as part of the framework?
Yeah, I think we should. I am still trying to work out how we absolutely should consider it. Some of the issues with the legalities is that it's so different depending on where you are. Certainly in the US, it's very different in the UK, and the litigation risk is possibly higher. And so it's about how to really frame that in a way that does not favor one health system over another, and can be potentially adapted, I think, by individual health systems as well. I think those are some real questions in my mind, and I think the legality is absolutely key to be able to address. And we have been thinking quite deeply about, you know, involving a legal expert as well in the task force as we do develop it. And our intentions are, you know, we're still looking for funding for all of these different different task forces that we're doing for these special populations, but you know, maybe involving a legal expert in addition to our policy researchers is something that we have been contemplating.
And I appreciate you're very early on in this project, but what do you expect, or what are the challenges that you've already encountered when working with this specific population?
I think one big challenge is that it's actually very difficult to find clinicians that are interested in being involved in the development of this framework. I have actually reached out to many, and I'm not sure, and maybe I'm just not aware enough because I'm not an obstetrician or gynecologist myself, but I don't know if it's a time issue. I don't know if maybe there's reluctance to really discuss the ethical tensions here because it's unclear as to where AI in the field may go, and if there's a digital literacy kind of talk that needs to be had. But one challenge, very practical challenge we have had is actually setting up this task force with enough kind of input from clinical professionals as well as technological professionals that work within the field, which is why I was really hoping, you know, getting here early would be a good thing. And if there is anyone that is interested, to please reach out, because we do need perspectives here.
Yeah, it's interesting that you raised this as the main challenge. I would expect funding to be an issue because it's often an issue when it comes to research in women's health. But one thing I wanted to share is I've recently done some user research with gynecologists, and one of the findings that came out from the work I've done is that a lot of them self-describe their knowledge of about AI as very minimal. So I wonder whether that could be one of the reasons why you struggle to find people who are willing to give feedback or insights into the ethical dimensions, perhaps because they just don't feel qualified to do so. So this is just an hypothesis, but it would make sense given my own conversations with gynecologists.
Yeah.
So in that case, it's really a matter of like engaging the community as a whole to be able to share practices and knowledge across fields, so that, you know, gynecologists feel entitled and allowed and enabled to, empowered perhaps, to have an opinion as to the ethics of, because they do have, at least in my own experience, they genuinely have opinions, but perhaps they don't feel like they are, you know.
I That's a really big thing that we're encountering in all specialties, certainly within dermatology as well, where a lot of clinicians are feeling like they can't talk about AI because it's a technological issue. But I think really raising the fact that it is both a technological and clinical issue, and without one component, the other, and I'm sure Tom will agree that without one side, it's very hard to function from the other. And really answer the question. So yeah, I think reaching out to the bigger bodies has been on my mind as well, such as the RCOG, and seeing if people are willing to do anonymous surveys and feedbacks. Yeah,
I think we've got one question. Jen, would you like to? Yep.
So I am an obstetrician. I'm in the UK. I was just I mean, I think this is really interesting. I think some of the things I'm new to AI. I'm a statistician really by discipline, and do lots of observational studies. But one of the things that's really kind of burns my mind about these things is that in maternity we have a really, we have this problem about competing risks that occurs the whole way through pregnancy. So we observe a lot, but at any point you can end the pregnancy. Well, and particularly like from the third trimester, once something starts happening, you can end the pregnancy, and then the risk of stillbirth goes. And I think, people get very mixed up in algorithms quite quickly. Like clinicians, I mean, obviously I'm a clinician, but like clinicians get very mixed up in what an algorithm actually means, because although obstetrics actually more than many other clinical specialties really does work on algorithms, it's very, and people think the algorithms are more evidence-based than they are, because most of them really aren't at all. I think people get really lost when they realize that actually a lot of the things that they take for granted, like competing risk, is often not built in very well, because actually what people want to measure what people want to measure is a hard endpoint, which is actually one thing. And it's very interesting hearing you talk about like the problems that I think are actually easier to solve. So like diagnosis of trisomy 21, we all explain all the time uncertainty about diagnosis of trisomy 21. You're completely right. That's something that would be very, very, very amenable to dealing with an algorithm. But actually where all the gain is here is like in managing labor, or managing care in pregnancy, to try and work out where the small babies are, where the babies that might die are, all of those sort of things. And it's just really hard to handle. And I think almost getting to the point where that problem can be understood, or people can communicate about it, is actually really tricky, I think. And I think I can see how you've got, but yeah, anyway, I'm going to drop you an email.
Good idea. Lots of conversations to be had.
Valuable. Just talking to you for 10 seconds is, opens my mind up to so many other ideas. And I think this is the other thing, there are many people interested in the equity aspect, and certainly I'm not an obstetrician or gynecologist myself, but I am very interested in pushing the equity frameworks to all the groups that need it. And without your clinical expertise and being able to really direct us, I think it's impossible to do. So please do, this is very open to tweaking. This is very open to criticism as well at this stage, and I welcome it. So please do email me, and give me your thoughts.
No, it's really interesting, because this is largely why I'm here, because I'm trying to work out how this all fits together.
I'm so glad you are. Thank you.
There's a final question from the chat as well, actually two. But if there's obviously other questions, feel free to contact both speakers, in fact, and continue this conversation after the end of this meeting. So there was one about how do you feel you would increase the trust in the AI from the clinical perspective, I suppose, and would a model explaining the reasoning in text improve confidence? I think that's quite it's assuming that you've already got a model or something to.
I think that's an important question to answer, and I think this comes down to how people are maybe perceiving some of the AI research. I think those of us that are certainly working with algorithms are, we really want to push forth the message that AI research is very much in its infancy in every field, I think, and I don't think the education is such that we say that it will definitely work, but I think the education is in saying that there are some technological means that we might be able to make things better through that may not work, but are you willing to open your mind to it? And are you willing to try and offer us your perspectives? I think that's more the question. So I think that's I'm glad that that was brought up, because I think there is this notion that, you know, people who do AI research are 100% you know, very optimistic about it. And I'd actually say the opposite. And I wonder if many of you would agree with me in that. I think we're quite neutral about it, and we're, you know, we're excited about it because we think some things can work, but we also, you know, operate with a healthy amount of skepticism, I think. So yeah,
this is definitely something we will explore next session, so I'm glad you brought it up. In fact, our next online meeting will be in September, given most of us will take a break over the summer, but this is definitely something that we need to all think about for all case studies and all applications of AI. So please stay tuned. The date will be confirmed soon, but probably in the later stage of September. And I would like to thank our two amazing speakers again for joining us and presenting such an important and amazing work today. And thank you all for coming and joining us as well. And have a lovely summer. And I hope to see you very soon for our next conversations. Thank you very much.
Thank you.